Welcome to today's Explainer, where we're going to dive right into the incredibly high-stakes reality of cardiac trauma. We're talking life or death here, and along the way, we're actually going to shatter a pretty dangerous medical myth.
So let's jump straight into this provocative question, because honestly, what you were likely taught back in med school about cardiac trauma, it could cause a fatal delay in the trauma bay. We're going to look at exactly why clinging to those classic textbook symptoms might literally cost a patient their life.
Just to set the stakes for us, penetrating cardiac injuries carry a staggering overall mortality rate of 94%. Think about that for a second. That means when you're in that ER, there is absolutely zero margin for error. None.
Here's our roadmap for today. We're going to move rapidly from the physical mechanics of the injury straight through to the life-saving damage control surgery.
Starting with Section 1, Mechanics and Vulnerability. Let's first figure out exactly which chambers of the heart are in the line of fire when kinetic energy hits the chest.
Because of how the heart sits in the chest, the anterior-facing right ventricle really bears the brunt of the trauma. As you can see, it accounts for 43% of all cardiac lacerations, followed by the left ventricle. That anatomical setup completely dictates the absolute mess you're going to see on the operating table.
Moving to Section 2, Anatomy of Catastrophe. Let's talk pathophysiology, specifically how the pericardium acts exactly like a rigid, locked box during an acute trauma.
Here's the terrifying part. A rapid accumulation of just 60 to 100 milliliters of blood catastrophically maxes out the pericardial reserve. The fibers just can't stretch fast enough. So what happens? You get an exponential, lightning-fast spike in pressure that basically crushes the heart from the outside.
This massive external pressure completely prevents the right side of the heart from expanding outward. So during inspiration, the interventricular septum bows sharply to the left. It literally crushes the left ventricle's volume, causing a massive drop in systemic blood pressure. That right there is the mechanics behind Pulse's paradoxus, a huge red flag for tamponade.
Section 3, Beck's Triad. Here is where we completely dismantle a very dangerous myth from 1926.
Look, we were all taught this triad as the golden rule, right? But relying on hypotension, distended neck veins, and muffled heart sounds is a deadly trap. Why? Because the complete triad is missing in 90% of acute trauma cases. 90%.
Let's be real. In the pure chaos of a trauma bay, a patient who is rapidly bleeding out simply doesn't have the blood volume to engorge their neck veins. They are profoundly hypovolemic. And muffled heart sounds? Yeah, right. There's absolutely no way you're hearing those subtle acoustic changes over the screaming monitors and a loud active trauma team.
Section 4, Diagnostics in Chaos. Since the textbook signs are out the window, we need definitive, reality-based diagnostics that work right now. Now, bedside ultrasound, like the FAST exam, is a fantastic rapid screen, but concomitant injuries like a hemothorax can easily give you false negatives. Here is a crucial clinical point. If your patient is critically unstable and the ultrasound shows tamponade, you must perform an emergency pericardiocentesis immediately. You take a long needle, go right under the xiphoid process, aiming for the left shoulder, and aspirate. It's a vital bridge to surgery. However, if the patient is stable but has a wound in the cardiac box, the absolute gold standard is the subxiphoid pericardia window.
Section 5, Subxiphoid Window Technique. Let's step into the OR and break down the step-by-step execution of this definitive procedure.
You have to follow these steps methodically, and I really want to emphasize step 3 here. I literally cannot stress enough how critical strict local hemostasis is before you cut into the pericardium. If you don't stop the bleeding in the abdominal wall muscles first, that blood is just going to pull into your surgical window, giving you a completely false positive.
If your hemostasis is solid, the visual answer is immediate. Clear or straw-colored fluid. You're good, safe to close. But if you see frankly bloody fluid or fresh clots, that is your cue for an instantaneous conversion to open the chest. No hesitation.
And finally, Section 6, Damage Control Surgery. If that window is positive, or if the patient rolls in already crashing, we transition instantly to extreme surgical control.
When the heart is actively bleeding right in front of you, standard flat gauze won't do a thing. You need immediate fingertip pressure right on the hole. For deeper tracks, slide a Foley catheter in and inflate the balloon to tamponade it from the inside. Or grab a skin stapler for a rapid temporary closure. Studies show it's way faster than trying to throw sutures into a beating, bloody heart.
Once you've got temporary control and you're moving to definitive suturing, keep this in mind. You absolutely must use round-bodied, taper-point needles with Teflon pledgets. Using standard cutting needles will literally slice right through the contused, fragile heart muscle, causing a fresh, catastrophic bleed with every single pass.
So the final thought I want to leave you with in this explainer is this. In those chaotic seconds of a trauma resuscitation, when a life is literally on the line, are you going to trust an outdated textbook myth, or are you ready to take decisive action based on physiological reality? Hopefully this breakdown helps you make the right call. Thanks for hanging out with us. Keep learning, and we'll see you next time.